Hi, thank you for coming and sharing today. I really appreciate it. I'm taking it to another point here because I'm on Revlimid for maintenance. It will be 2 years in December, and I'm a Kaiser patient, and I think we finally have agreed that I can continue my Revlimid maintenance as long as side effects are fine, et cetera. But my question precisely is, I had heard a few months ago, and I don't know which webinar it was, but that Revlimid was possibly going to be created into a patch, which might change some of the side effects, especially maybe physical symptoms that I'm having or neutropenia. And I was just wondering if you have an update on that.
I think I can take that one. Are we on? Thank you for asking that question. It's a good. So again, the question, I guess you have a microphone too, but the question would be lenalidomide, Revlimid, is the patch happening? And so as far as I know, they're still in studies. I haven't heard anything as of the last month that would say that it's ready for prime time, or commercial approval, I should say. The one nuance I'll add is that unfortunately, when a new drug comes to market, even if it makes more sense for patients, it doesn't mean that it's cheap. The example I'll give just as an example of that is with dexamethasone. Everyone in this room has either prescribed or taken dex. I see a lot of nods here, right? And people ask all the time, why is this so dumb? Why am I being asked to take 10 pills at the same time? They actually make dex 20 milligram pills now, and they make dex 40 milligram pills. It'll be 1 or 2 pills a week. It's called Hemati as the brand name, but it costs like, $4,000 a month, something crazy, and so no insurance company covers it. So my word of caution, I'll be as optimistic as I am, and I'm glad that they're looking into that. I would say that even if it does get approved by this time next year, that doesn't mean that any insurance, including Kaiser, will cover it. If you are running into issue with lenalidomide, with Revlimid, I would definitely talk with your physician, because for a lot of my patients, when I tell patients about Revlimid, is that all the studies did 10 milligrams after transplant up to 15 milligrams. Whether you are a 300-pound linebacker or a 78-year-old grandma, same dose for everybody. And that doesn't really make much sense at all. And in real life, we can often go down the lenalidomide, the Revlimid, to 10 milligrams, 5 milligrams, 2.5 milligrams even, or a different medication for maintenance. So I would say that if you are having side effects that you've noticed, I would talk with your doctor about it. And there may be either dose reductions or treatment holidays or even another maintenance strategy that might work. Anything else you guys would add?
Awesome. Anybody? Next question?
Thank you, everybody, for being here. How does the number of cells that you need for an autologous stem cell transplant relate to the number of cells you need for CAR T-cell therapy? And the reason I ask is, half my cells were frozen after my transplant. So if apheresis is a bottleneck, can you just use the cells frozen after a transplant?
Yeah, I can take that one. The stem cell transplant, the autologous peripheral blood cells for CAR T cells, is that correct? So this is a very common question, and the short answer is no, we can't. I know that there are some investigators out there looking at this, because obviously, stem cells are pluripotent, right? Pluripotent in biology means they could become any cell. So could we somehow coax those stem cells into becoming T cells? I mean, it's the advances in science and molecular biology and genetic engineering are pretty amazing. And so I would say, never say never. But as of today, that's not available, and I wouldn't anticipate it's going to be available for a while. But it's certainly something people are asking about. So I'm glad you brought it up. I don't know if any of the other group have something to say about it.
Maybe one nuance. Oh, go ahead, sir. Go ahead.
I was saying, why isn't it available at the moment? Is it just because the door is open?
It's just there's nobody has figured out how to do it. That's really what it is. I think there's definitely efforts to try that I'm aware of, but nobody has sort of cracked that puzzle yet.
And I'll add one question you didn't ask, but a related question. So I agree with Dr. Cowan entirely that the stem cells, it's hard enough for it to get T cells to grow in a lab. To get stem cells to actually grow into T cells and then turn the T cells into CAR T cells, we're not there yet science-wise. People often ask, well, should I even bother with my stored stem cells? That's also a very personal question to ask with your physician. Some insurance companies just pay for it. Others, they're getting a threatening letter once a year being like, pay up or we're going to throw away your stem cells, which is a very odd and I would argue threatening way of doing it. To Dr. Cowan's point, there may be a scenario where those stem cells do come in handy for ways that I can't entirely envision yet. The other thing I will briefly add, Dr. Cicero briefly talked about some of the side effects of CAR T. CAR T therapy sometimes can cause low blood counts for months afterwards. And so there are patients where they're in remission, but their bone marrow is so beaten up from all the therapy and now the CRS that they've had that they're just, they're still needing transfusions, they're still needing growth factors. And there, the stem cells frozen from 2016, no chemo, just give them the stem cells back, what we call a stem cell boost, might sometimes be an option. So I would say if the question ever comes up, should I save my stem cells or not, talk with your doctor, because there's a lot of nuances that even I don't fully appreciate yet.
Yeah, I completely agree with Dr. Banerjee. In fact, we've done this for patients at our center, and it's really been pretty remarkable in how it works. So, again, unlikely that, how likely is this to actually happen in the future? I mean, probably not, but, if they're there, and, it's not too much of a burden to keep storing them, I typically have advised people to just keep storing them.
So I had a couple questions. First is just with 1Q gain. I can't remember where I've heard it, but like 3 copies isn't really high risk and more is, and what everyone's opinion about that is, I guess. And then Kyprolis versus Velcade. Everyone talks about neuropathy being still awful, but I was wondering why don't people use Kyprolis more? Maybe its side effects are way worse, I don't know. And then the last is about exercise. I'm smoldering. I like to go to the gym. I like to lift and do things, and I'm almost afraid to lift a weight, and I don't know a resource. Maybe I should talk to you about how much I should be doing.
You asked all the questions. The easiest one is not easy at all, but the lifting weight thing, it really depends on what's going on with you, as well as what you've been doing previously. So if you, and I don't know, if you are a internationally known power lifter, then I think you're probably fine because you know what you're doing. But if you want to just learn how to do this for the first time, then I think that working with somebody who can help you learn how to do those exercises correctly with like appropriate form is very important. And then just keep checking in with your primary care doctor as well as your myeloma doctor about what you're doing, how you're feeling, if you have pain or not. The 1Q gain one is tricky. Do we want to leave that one to the end, or do we want to just jump into it now? The 1Q gain one is tricky, and you're absolutely right. It's evolving. We're learning more that specific copy number is important. I don't know that we know what the threshold is of how many gains are extra bad versus just not great. But it's new enough that we have, or at least I have conversations with the pathologist sometimes and be like, can you tell me how many there are? Because I've got some patients who are very, very informed and very interested in knowing exactly how many they have. How are you guys risk stratifying based on numbers?
I mean, yeah, I concur with you, Dr. Silbermann. National Myeloma meeting, in fact, it was discussed that would likely, although it's still TBD, be considered to be sort of the new high-risk definition. I mean, wasn't that correct in one of Dr. Munchi's presentations, Rahul?
They say that. Might also get published anyway.
Yeah, who knows? We'll see. And so I think it's a tough conversation. And like I mentioned when we talked about high risk, we get really hung up on these high risk markers, and I think it's really important that it's a risk factor. It's not your fate, sort of written on the wall. It's an indelible ink. It is an educated guess, and I think it's really important. And also, the conversely, standard risk does not mean everything is always going to be okay. We know that there are some standard risk patients who we meet and we say, oh my gosh, you're standard risk, this is great, and then things don't turn out like we expect. And I think that just highlights how sort of imperfect these tools we have. And so, yes, it's important to know, are you likely high risk, but it's also, you have to take it with a grain of salt. And I'm sure most of the panel would agree with that.
I agree with Dr. Cowan and Dr. Silbermann. I think that one of the biggest things is just how many copies of the gain you really are having, whether it's 3 copies or 4 copies, I think makes a big difference. What I think Dr. Banerjee talked about before, if it's in combination with other high-risk markers, I think that that's the important thing to think about. And then Dr. Banerjee actually recently spearheaded a review about functional high risk. So kind of what Dr. Cowan was just talking about. Some of these features might not actually, it's our best guess whether or not someone will present aggressively and whatnot, but at the end of the day, there are many cases where someone has high-risk features and they don't behave high risk and vice versa.
Agreed. And so I'll just add, for those who are wondering, what is this 1Q business? On a bone marrow biopsy, all of your cells are normal, but the myeloma cells sometimes have cytogenetic or genetic abnormalities at a chromosomal level. Many of you heard of deletion 17p or chromosome 14 issues. Gain 1Q is extra copies of the short arm of the first chromosome. And I would just echo the fact that the number of copies probably matters. The issue with 1Q in particular is that there was recent data studied this year that 1Q might not necessarily be a driver, it might be a passenger, which is also a weird car metaphor, but not my other set of car metaphors, a different set of car metaphors here, where the idea is that if you just, over time, everyone starts to develop more of the myeloma cells having 1Q, they just grow a little bit faster, but it's not driving inherently resistance to therapy. AMP1Q, when there's 4 or more copies of that, probably does portend a slightly higher risk of earlier relapse after therapy, Dr. Cicero just alluded to. So that I would treat the way I would treat other patients in terms of doublet maintenance. Dr. Cowan alluded to this, having 2 drugs for maintenance and not just 1, but it's complicated. For your question about carfilzomib versus bortezomib, so carfilzomib versus Velcade, it's even more complicated. There was a very large study called the Endurance study, actually a cooperative group study, so actually funded by the government and by investigators like us, that showed no difference between KRD and VRD, and Kyprolis actually maybe had even more toxicities. The big issues people sometimes have are high blood pressure, or rarely heart issues can happen, but rarely there can be kidney problems as well with it. That study didn't look at high-risk patients, so there's a lot that we don't know. I think, in medical school and training, I was taught with the 2 extremes. Like someone who has, extremely bad heart function, Kyprolis is probably not a good option for them. Velcade might be better. Versus on my board exams, it's always the virtuoso violin player, the one who needs their fingers and neuropathy would be terrible for them. Velcade is not a good option. I would argue everyone in this room needs their fingers to work, whether you're a violin player or not. So it's not that simple. So I would say, in my book, I typically do use bortezomib, so Velcade as part of my frontline regimen based on the Griffin study that most of the speakers have already talked about, and I save carfilzomib for later lines of therapy. However, for someone who does, if neuropathy is a big problem for them, or if they have issues with bortezomib for some other reason, I think Kyprolis is very reasonable. We can go back this way. I don't know if you guys have thoughts about that.
No, I agree with everything that you've said.
The other piece, which is really hard for everybody, us included, is that all of this also changes. And so there are still ongoing studies that are looking at upfront carfilzomib in other combinations. And it could be that in 3 years on the same stage, we'll have a different answer. And so I think that's sometimes hard for patients to kind of swallow, that we just have to realize that this is where we are right now. We're doing what we think is the best decision making for each individual based on what we know right now, and that could change.
When you were talking about this saving stem cells, when I asked to have mine saved, they said no. And I don't remember why, because I was overwhelmed, but I understand that's becoming somewhat common not to save them. Is that so?
I'm a little surprised they just said no, but I know that in some situations, mainly I think depending on, the age of the individual, we save for a second transplant. And so if someone's getting a transplant at like age 75, we might not save. We might just do enough. So we'll have to talk afterwards about this. I want to know more about this because
next time we're in clinic, we'll talk about that for
so
sure.
I think you raise an important. I mean, so we all. This is the there's many different people who treat multiple myeloma, and there's transplanters that aren't here who treat multiple myeloma, and there's sometimes differences of opinion on the utility of certain things, and this is just one of them. So I know this has come up, and I think I have heard sometimes that the transplanters might not want to save cells for someone above 70, and I don't know why that was chosen, probably somewhat arbitrarily. I'm interested in if any of my other colleagues have insight onto this.
Well, sometimes there aren't enough cells to save.
But isn't that when they help you get more before you actually have the transplant?
Sometimes they can't, though.
Oh.
And so that, I think, is important to realize that even for patients who might be young, if they've gotten very intensive treatment, sometimes you do all of the things and take all the extra medications, and you just aren't able to collect quite as many as you hope for.
And we have to use all the cells that we collected to do the transplant. So there's a minimum number. Usually it's 2.5 million per kilogram.
Yes.
And if you get around that, you can't save whatever's, there's nothing left over. You have to use all of it. And so that there's probably, multiple factors that could be at play.
And the other nuance, and I will review your case next time we talk in clinic, because I know I met you for the first time last month, from Dr. Lee leaving the practice. But the other nuance I will say is that the pandemic did change things. So, this is also, the science is evolving here, but I will say for many of you who may have been transplanted or been collected between March 2020 and even maybe this summer, the center may have said, we don't have the capacity to store stem cells now or to do some of the more things just with the change in the nursing workflow and just some of the chaos that all of you lived through. So that may be part of it. I will say, if it's helpful, that the Center for International Blood and Marrow Transplant Research, the CIBMTR, did an analysis, and the vast majority of stem cells that are saved for a second transplant never get used.
Oh.
So it's not something, it's relatively uncommon. I know I just mentioned that as a possibility, this idea of a stem cell boost after CAR T. That is pretty rare. We've probably only done a handful of times. And as CAR T moves to earlier lines of therapy, which I alluded to in my talk, right? Healthier patients, healthier T cells, less beaten up bone marrow, the odds of those stem cells actually ever being needed for CAR T are probably going to get lower and lower. So I wouldn't necessarily view it as a negative thing at all.
Okay. I'll talk about it next time I see you.
All right, I'll be ready. I'll be ready.
So I have a question. Can you hear me? I have a question about Zometa. If you have a stem cell transplant and then you do the 2 years of Zometa, can you think of any situation where at a later date you go back and get it again?
It's really complicated, and it's really not clear, is my opinion of it. I have started to get bone density tests more frequently on my patients. If I can show that a patient has lost bone density despite having gotten that 2 years or 1 year or 10 months, some amount of the Zometa, then I go to my endocrinologist colleagues and I say, could this patient be a candidate for one of the newer bone strengthening medications? There's a medicine called romosozumab, which is pretty cool, which does seem to help improve bone density in some individuals. Some of the older medications that worked in that way had a warning on them that said they were not to be used for patients with myeloma or plasma cell abnormalities, but this one is different. But it's not in my closet. It's one that I need to get my colleagues to help me with. The other potential reason would be if someone has new bone lesions that pop up on an imaging study. The older thinking was that, yes, that would be your indication to restart the bone-directed therapy. I think it's getting a little murky right now because we're realizing that there are problems sometimes associated with giving Zometa forever and ever and ever, and so I think it's difficult.
Yeah, I agree completely with Dr. Silbermann, and I would also add that so previously we used to give bisphosphonates for maybe 2 to 3 years and then stop, and then the teaching was you restart a bisphosphonate when someone relapses. And I think part of the reason for this was the MRC9 trial that was discussed by Dr. Silbermann had actually shown a survival benefit, not just not just less bone lesions, benefits. So people who got Zometa live longer. And so for a while, people were like, well, Zometa has a direct anti-myeloma effect. I'm frankly not convinced of that. I think that those data are really old really old in myeloma is like 10 years, right? So, but in the academic world, that's like ancient history, right? I'm not sure how meaningful that is. I'm not personally convinced that Zometa has a direct anti-myeloma effect. And so I think it is, I agree completely, it is a very nuanced discussion. There are certainly risks to bisphosphonates. It's not just the ONJ, it's hypocalcemia. And especially with denosumab, I've seen severe hypocalcemia that's landed people in the ER. And hypocalcemia can cause cardiac arrhythmias. I'm not convinced people are well counseled about this. So I think it is a very complicated discussion, and I agree.
And I'll just add, so several of us were in Athens last month for the big myeloma meeting. So the Danish group, not the dessert, but the Denmark people, presented a study of 4 versus 2 years of Zometa. And they did find that there was fewer skeletal progression events. So the myeloma still came back at the same rate, but less likely to come back with spots in the bones. But there were more cases, numerically more cases of osteonecrosis of the jaw that we talked about. And so I would say that that's, and some of you may know, I know in myeloma fighters, I know in the Seattle area, I'm aware of patients who've had ONJ osteonecrosis, and it's really scary, painful, really problematic on a lot of fronts. So I would argue that if I'm worried about someone, what I would actually do is instead of giving them more than 2 years of Zometa, I actually try to implement whole body CAT scans as part of my surveillance strategy. There is some evidence for that. Most of you who are on maintenance are just getting blood work and blood work and blood work. If for some of my patients who've had very aggressive spots on the bones when they were diagnosed, I do add on a once-a-year CAT scan. This might be more controversial, maybe not, for those patients if insurance covers it. And I would argue that might be a more proactive way to identify relapse like that. It's a CAT scan, some side effects to a CAT scan, but not nearly as much as continued Zometa.
Yeah, so my question is, as somebody on 5 milligrams of Revlimid who is not a candidate for the stem cells because we're at high risk, and having very severe spasms, 2 to 3 a day, the hands just crippling, the feet are crippling, dropping stuff, and realizing, that it looks like I might be on this like forever. What are some of the alternatives or things that you have that might help with those symptoms? I'd be interested to hear what you have to say.
It's tough. I'm sorry that that's happening. And some of you have heard my talk to HealthTree. I gave up a dexamethasone, and I said dexamethasone used to be the hero, then it became the villain. Revlimid someday will be the same way. So we have all these newer versions Dr. Cowan alluded to, for example, cell mods that are coming. My hope is in 10 years, this whole Revlimid nonsense will be gone. Unfortunately, we're stuck with it, and it does have a lot of side effects. If you don't mind me asking, are you taking it continuously or 3 weeks on, 1 week off? So that might be one easy place to start with. Many of the studies of lenalidomide actually started with 3 weeks on, 1 week off. Why? For exactly this reason, because even on maintenance, the toxicities are real. And if you maybe start with that, you may find that that might help with some of the side effects, and you could point to it and say, look, when I do 3 weeks on, 1 week off, my off week, I feel better. I have proof in the pudding now. This is the Revlimid and time to play around with it. Especially if that's the case, or if these symptoms get worse, I would say you can speak with your physician for sure about pomalidomide could be considered. Sometimes different IMiDs don't have the same side effects. Pomalidomide is a newer version of Revlimid. Depending on your particular case, some of my patients can't get Revlimid. One of my patients, also myeloma fighters, had a very bad skin reaction to Revlimid, and so she's on Velcade instead as maintenance every 2 weeks. So we can proceed with other options instead. And then the last thing, Dr. Silbermann had a really excellent presentation about kind of wellness-related tips. Depending on where you seek care, a lot of centers do have an integrative oncology practice or integrative center or somewhere along those lines. I've had some patients where any combination of acupuncture, of mind-body medicine, of even like topical CBD, things like that actually tend to help a lot, even if we can't get off the lenalidomide, off the Revlimid, or even like magnesium supplementation, although mag has its own side effects. So there may be ways to help mitigate the impact that those cramps are having on your quality of life, but it's tricky.
Sometimes it makes sense to also just make sure there's nothing else going on. So checking that thyroid hormone is okay, making sure the other electrolytes are okay is important. And then it sounds silly, but coconut water, pickle juice, yellow mustard, those things actually do help for some patients, particularly if they like pickles. Otherwise, don't do that. But some people really do find some relief in the cramping symptoms with those kind of simple things too.
Yeah, I would also just add that sometimes I've had patients that just can't take Revlimid. We try everything, nothing works, and that's okay. I mean, even if we have the right tool, if the right tool is not working for the patient, then it's the wrong tool, right? So, even though Revlimid has a survival benefit, if it's not working for you, it's not the right tool. So I would, typically, you'd want to have a good conversation about alternatives. I agree with Dr. Banerjee. There's data for other drugs in maintenance. Velcade is one. Carfilzomib has data. Daratumumab from the Cassiopeia trial has pretty dramatic data for maintenance. And so, there's no reason to suffer unnecessarily on Revlimid.
So I think Dr. Cowan has to leave early.
Thank you. Yeah, sorry.
So thank you so much for spending your Saturday with us, and we're so appreciative. And the other three, we still get 10 more minutes with them to ask questions.
Thanks, everyone. So good to see you all. All right. Thanks, Andrew.
My question is to Dr. Silbermann. You mentioned at the end of your presentation that you don't know how good, did I hear this correctly? You don't know how good the quality of the bone is necessarily on some of these. Did I hear that wrong? Or was
No,
that
you
correct?
heard it correctly. I think it was in the context of if it looks like a bone is healing after someone's had a bone lesion there. There's a whole world of people who are very interested in bone metabolism and the quality of bone healing that occurs. And in addition to having new mineral laid down, one normal aspect of the bone healing process is that bone remodeling, where bone is taken away again and then laid down again, and then you can form that very strong, it's called woven bone. And the theory, or I don't know, my thought is that suppression of the osteoclasts with the bisphosphonate, like the Zometa, giving people monthly dosing for such long periods of time, you end up with skeletons that are absolutely filled with the drug. You're never gonna not have that drug in you, and you may not ever have normal osteoclast activity. I don't know if you remember hearing maybe 10 years ago about how some people were developing what were called atypical fractures when they were on pill bisphosphonates like Fosamax and things like that.
Right.
And the thought, as I understand it, is that those occurred because the bone was stronger, but it wasn't having that remodeling occur. And I don't believe that I've seen good data saying whether that's actually occurring in myeloma patients. The tendency to say is to say, okay, a myeloma patient has fractured because their myeloma got worse, not necessarily because it was a long-term drug effect. We can't tell the difference about it. But that's where I was going with that piece of it.
And my question is then, how do we educate ourselves about how to build and then maintain quality bone? Because for my husband, I'm not sure I want him on Zometa. I'm not sure that, are there other things that maybe not drug related, but other things that we can be doing to build quality bone and maintain it? And where would I go to educate myself about that?
Yeah, so I think that it's incredibly important to know about the issue, which you do. I think that Xgeva or denosumab is something to think about. It works in that different mechanism. And as I mentioned, it is reversible, which is good and it's bad at the same time. It's given as an injection under the skin. I don't know what's going on in Seattle. In Portland recently, the insurance companies have been a little stubborn about the denosumab, and I don't really know why, but these things, they come and go. It's like seasons. I think some degree of bone-directed therapy is important. I think that the adequate calcium and vitamin D is extremely important. I think it's a reasonable conversation to have with your team to say, these are my worries. And they might say, that makes sense. This is a person who does not have any bone abnormalities that we can see. Let's try to use a minimal amount of medication.
Thank you.
Sure, sure.
Can you hear me with my mask on?
Yeah.
Good, okay. So I'm in my third year of treatment, and my starting line of treatment within that. I was previously in my third line on Pomalyst, and that wasn't doing a whole lot of good. And so, because I have the 1114 DNA marker, my oncologist wanted to put me on to venetoclax, which was a whole insurance nightmare in and of itself because it's not FDA approved for multiple myeloma. But they eventually, through appeals, got it approved. So my light chains have gone down to the lowest point that they've ever been in 3 years, which put me into clinical remission, which is the good news. The bad news is I feel awful. And so I still work. I travel a lot. I have fatigue is worse than it's been in previous lines of treatment, and I have pretty bad shortness of breath. So when I'm traveling, which I do frequently, it's really become difficult. How do you, what's your experience, if you have experience, with venetoclax as a treatment? And secondly, how do you balance the quality of life issue with the fact that, from the efficacy of the drug, it's working, but the problem also is that in clinical remission, unlike previous remissions that I was in where the drug dosage was reduced to like once a month from 3 times a month, I'm on the same course of Cripolis, venetoclax, and the famous Dex, 3 times a month. So it's not changing my drug regimen at all, and therefore, the way I feel is not going to get any better, even though my markers are there.
Yeah, I can take that first, and we can talk about it. So just to reorient the audience here. So venetoclax is approved in AML, other blood cancers like lymphoma and leukemia, not approved in myeloma yet, but we've seen great results with T1114. Just in case any of you read the news or look at HealthTree's updates, last month there actually was a negative study where venetoclax didn't outperform standard therapy, but I think the study was not properly implemented. Long story short, that we can talk about later. So I actually do think venetoclax works quite well for 1114. If you don't mind me asking, are you on 800 or 400 milligrams with the venetoclax? Do you have
Well, I started out at 600, and I'm now down to 200 because it was, the fatigue was a lot worse than 600. So my oncologist brought me down to 200, and she also reduced my Cripolis, lower also to see if that would balance out the fatigue and the shortness of breath.
Yeah.
Shortness of breath is a real problem. So for instance, like on a CTAC, I'm going from 814 to 81. Those people who live here, it's like I've got to stop twice in between to catch my breath. So my quality of life is like getting worse.
So your oncologist, I would say, has done a very good job. Venetoclax, a lot of oncologists don't know if that's an option, and I'm glad that your oncologist, she was able to lower the dose, because I would agree with that. I think if you're in a remission, and if plus or minus with a bone marrow biopsy to prove it, I think it's reasonable to try a treatment holiday, something to talk about with your doctors, the pros and cons of if I pause versus start and see how that helps. The other thing to keep in mind would be, having either your oncologist or your primary care doctor taking a good look at you and say, look, none of us are getting any younger. Is there anything else that can be causing me to be fatigued? Carfilzomib can cause heart issues, for example. We're getting another echo, getting things like that. things to think about, but it's tricky. I would say that if this is line number 4 for you, if and even if you were to stop all therapy now, as soon as the myeloma decides to even creep up a smidge, you're eligible for CAR T therapy, which would be, so I think, you're right that all of us as patients and physicians are addicted to lifelong therapy. Most of us in the room probably are still on some form of Revlimid or something for indefinitely. It may be that you may be able to get several years of mileage, or at least several months, 1 to 2 years of not being on therapy. Dr. Cicero, Dr. Silbermann, anything you'd add?
I agree. I do too. The one thing I would add is that I sometimes think there's value in patients trying to calendar it out a little bit. Just don't go insane with it, but just try to write down, all right, I get my infusions on Monday, which is my really bad day of the week? And if you do that, then sometimes you can start to see the patterns, and you might realize that it's always 48 hours after you take the Carfils, or it's always, a set time point after you take the Dex. And then you can work with your team to see if you can adjust that a little bit and try to figure out where things are. The other piece that you were alluding to was that sometimes, short of taking a holiday, we talk about lightening the treatment a little bit more. So it sounds like you're still getting the carfilzomib 3 times in a month. Sometimes we step it back, we do it twice a month. Sometimes we cut the dexamethasone back more, but it's a real give and take, because certainly you've had a lot of challenge in trying to keep your disease quiet, and it feels like this is the secret recipe right now, but we want to make it manageable.
And the last thing I'll add, so I would argue, this is my controversial take, but as all of you know, so if someone's in remission, I don't think they need dexamethasone at all. Even if they're not, if they're on the way to remission, I would say don't need dexamethasone at all. And some of our research actually through HealthTree shows that, longitudinal dex, all of you in the room know this, we doctors present, we don't realize it, does have side effects, for example, cataracts and eye issues down the line. And so I think that could be one reasonable step to say, like, at least peel off the dex, see how that works, start to peel back the kyprolis, like Dr. Silbermann alluded to, and then, if a treatment holiday is necessary, it's necessary. Some of my patients, I'm surprised that as aggressive as their myeloma was, sometimes we do stop all therapy and they actually do fine. It's very difficult to predict.
Right. She did take me off for 2 weeks, but it
didn't do much. Yeah. Okay. Fair.
All right. We might have time for one more quick question, if anybody has one. No?
It's one in the corner and one here.
Oh, over here.
Thank you. My question was regarding, I know, the T-cell exhaustion that you were talking about. Is there anything patients can do, like food or exercise, natural things to help that?
My short answer is to ask me in 5 years, and we should hopefully know. One of, kind of like friend of the show, friend of HealthTree, Dr. Urvi Shah at Memorial Sloan Kettering in New York. She's done a lot of work around the microbiome, around gut microbiome, and I think definitely there's something there that she, thanks to her leadership and others in this field, are trying to figure out, that we think that basically there's something about what we're doing with our gut microbiome, the bacteria in our gut, that probably drives a lot of how exhausted or our immune system feels. I can't say that we know enough yet to say for sure. So I would not at this point in time recommend anything different in terms of your diet or exercise or anything along those lines. I think in terms of what could you do to keep your T cells fit? Honestly, I think maybe this is kind of a totally left field answer to your question, but I will say that sometimes I've had patients, by the time that they're referred to me for CAR T therapy, it's already, their bone marrow is beaten up. They've already gotten 5-6 lines of therapy, and I think they didn't realize that they could ask for an opinion at an academic center. And so what I would say is, I am happy, I think all 3 of us are very happy to see patients by Zoom, even if you live 6 hours away, just to check in and be like, you know what, we do have a clinical trial of CAR T, or this or that is a possibility. So kind of, make sure that when that time comes that it's your slot for CAR T, that, we have a slot with your name on it, so to speak. But that's not directly answering your question, but I would say that just being proactive, which all of you in this room are by virtue of being here, but knowing that CAR T is constantly expanding in terms of who is eligible for, and so sometimes we maybe find a spot to get your CAR T or a bispecific earlier than you might guess. Dr. Cicero, Dr. Silbermann, anything you'd add?
Awesome. Thank you so much. This has been great. If we can give them a round of applause again.